All right, I see we have many people joining us here for today's webinar. So glad you could take time out of your busy day to join us here. My name is Joe Gogler from the University of Minnesota School of Public Health, and today our interactive question and answer webinar is what does it mean and how do we measure quality in dementia care? Again, really glad to have you join us here today. Next slide, please. So wanted to thank those entities who have supported today's webinar. First and foremost, the Minnesota North Star Geriatric Workforce Enhancement Program, which in turn is supported by the Health Resources Services Administration, then also the Robert L. Kane Endowed Chair in Long-Term Care and Aging here in the School of Public Health at the University of Minnesota. Next slide, please, Ashley. So the genesis of today's webinar was really a very exciting paper that was published back in the fall in a really prestigious journal, Alzheimer's and Dementia, called Improving Quality Measurement for Dementia Care. Many colleagues I know and respect immensely authored this paper. As you can see, they are joining us here today as the panelists. And I really thought this was a great topic for this specific format of an interactive webinar. I think a lot of us wonder, how do we know when good care is being provided to someone living with dementia? And what does that care look like in different types of healthcare settings? And finally, can we actually measure that care? Can we create better measures to compare and contrast when good care is being provided to someone living with dementia and perhaps their care partners as well, and not? And that's what really attracted me to this great paper. Again, this paper was shared with all of you as part of the registration. Hopefully you've had a chance to access it. It is freely available. Again, we'll make a point to do so again after today's webinar as well, because I think it's written in a way, again, admittedly it's academic and scientific, but it's also very relatable and also highly impactful. And I thought, what better way to bring this work to the fore than to highlight it in our webinar today. So you see our speakers here. We have Dr. Sue Borson, who's co-director of the Building Our Largest Dementia Infrastructure, Public Health Center of Excellence on Early Detection of Dementia. We have Dr. Gary Epstein-Lubau, geriatric psychiatrist, Dr. Lee Jennings, who's a geriatrician, also involved in Oklahoma's Geriatric Workforce Enhancement Program and part of the leadership there. We have Dr. Zachary Kunicki, behavioral scientist, Dr. Matacruz Rivera Hernandez, a gerontologist, and Ellen Tambor, who's representing what's called the National Institute on Aging Impact Collaboratory. And Ellen leads much of the work in trying to center people living with dementia and their care partners' perspectives on quality in dementia care and healthcare settings. So thank you to our speakers for joining us. So next slide, please, Ashley. So we're going to turn it over to Ellen to kick things off. And as a reminder, everybody, the way this will work is I asked each of the panelists today to address one or more of some of the questions you pose as part of the registration. You'll see them do that in the first part of these really brief presentations. And then around 45 minutes into the panel, we're going to turn it over to a full interactive Q&A portion of the session. So I would ask those of you who have questions or comments to submit them in the Q&A function. You'll see that in the lower center of your screen. You can try to do it in chat as well, but it'll be harder for me to probably keep up with that versus the Q&A function. So please try to submit your questions there. And again, in the second half of today's panel and interactive webinar, I will be collating those questions and directing them to our wonderful panel. So Ellen, I believe, Ellen, are you first or is it you, Gary? Gary,
Hey.
I'm sorry, Gary. So we'll have Dr. Epstein-Lubau kick us off. What does it mean and how do we measure quality in dementia care? Thank you, everybody.
Thanks, Joe. Dr. Gogler, thank you very much. Great that we can all be here to talk through this really important topic. I'm Gary Epstein-Lubau, I'm a geriatric psychiatrist with Brown and with Education Development Center. And I got interested in this work back when I was doing some work for the Advisory Council at Health and Human Services. And this project took a long time to complete, and Ellen Tamber and I worked carefully on it when we were working together with the NIA Impact Collaboratory, and that's the slide are branded by the Impact Collaboratory because the majority of the work was done during that time. And Dr. Lee Jennings, tremendous gratitude to you. This was a complicated manuscript to get through, and you, as lead author, deserve tremendous credit for getting it over the finish line. If you can go to the next slide, please. Thanks, Ashley. Why this matters. High quality dementia care, evidence-based dementia care, there's limited access to it, and we need to all be doing work together to improve access to high quality dementia care. There are multiple domains of how that are included in comprehensive dementia care, and how those domains are divided. There have been different proposed ways for that. We chose one in order to get to definitions of quality dementia care, and measuring that quality within established domains is important so that we can make strides forward in those areas that are essential for and of high value for people who are experiencing dementia and their caregivers, and also for clinicians to know that the work that we're doing is consistently of high value. Next slide, please. Uh, Thanks, Dr. Grogler, for inviting us to present the paper. You showed it earlier. The objectives of the paper were to review the existing dementia care measures, describe where there are gaps in measures of aspects of dementia care, and then make recommendations for future directions. Next slide. Uh, this framework comes from a commissioned report that Health and Human Services did in 2016. There are several frameworks for elements of comprehensive dementia care. This one has 14 elements in it. We chose this one because it clearly defines multiple different elements, and because it had the history of having been commissioned by the US federal government. And when we get to recommendations towards the end of our presentation, that's one of the recommendations, is that there be a central entity like the federal government that would help move forward a framework like this for quality measurement. And what you see here, and this framework will come up again through our slides, are elements of comprehensive dementia care, somewhat in a time ordering. So early detection, diagnosis, initial assessment, and initial care planning are early on in quality measurement. Medical management and information education, informed decision making has to co-occur early on after dementia diagnosis. It's essential that there be acknowledgement of emotional support for the person with the dementia, and assistance for the person with dementia related to daily functioning and activities. For family caregivers, separate quality measures to make sure that they are involved and that there is emotional support and assistance for them. The prevention and mitigation of behavioral and psychological symptoms and safety are also essential components and can be separately measured. Therapeutic environment in this report from RTI was separated as a separate important component of comprehensive dementia care. Care transitions refers to care that occurs from one setting to another, such as when someone is in a hospital and then returns home, or moves from home into a supported facility. And then referral and coordination of care and services happens throughout the dementia journey. We'll return to this framework, and I think I hand off now to Zach to talk about how different measure sets align with this overall structure of these 14 components. Next slide, and over to you, Zach.
Awesome. Thank you so much, Gary. I just want to start by echoing your thanks to Joe, Lee, and the rest of the team for all the incredible work on this manuscript. And it's very heartwarming to be back together with you all. And I thank you for the opportunity, Joe, to do this. So, when talking about dementia care, as Gary alluded to, the first thing to do is review what is out there. So the review covered a number of categories. Sitting up here on the left, I'm going to resist the urge to PowerPoint karaoke too much, but just show that we went over a number of areas, including research-based, professional societies, Medicare and Medicaid services, policy, and international viewpoints. These gave us a number of different measure sets, including the ACOV-3, the Dementia Management Measurement Set, the CMS measurement sets, the variety of ones shown here, the National Quality Forum, the National Committee Quality Assurance HEDIS measures, the NICE measurement set, and the ICOM measurement set. Looking through these measures gave us an idea of how many of the different topic areas are we being covered. Prior to the talk, a interested party asked the question of how can healthcare providers reliably measure quality care in patients with dementia, considering clinical outcomes? And as a psychometrician, I had a hard time grappling with this question because I don't think this is something that I can say, oh, well, you need to calculate your convex alpha and see that it's above zero point 0.7 and you're doing a good job. I just don't think that that fits here. Um, I do think certainly that an estimate of statistical reliability would be important and useful. And I think the greater thing here is knowing what's out there and coming back to knowing what else needs to be discovered or what else needs to be created that we'll come to later in the talk is really starting to see how do these concepts and how do the points that Gary outlined in the previous slide, how are they related to the outcomes of interest? And defining what those outcomes of interest are. Are they the number of times someone is admitted to the hospital? Is it 30-day readmittance rates? Is it disability adjusted life years? Is it the Zara care burden inventory, or is it something else? But ultimately, I think there needs to be a call for additional research to show how do these different concepts or different areas of quality care relate to the outcomes we think are important. And I think that is the best answer I can give you there. Next slide, please. Thank you, Ashley. So, looking through the review framework, going over the different areas on the previous or the different measurement sets on the previous slide, we tried to see how many of the measurement sets that exist out there include that component. And for some of these, there's quite a good job happening. So we see that assessment and ongoing reassessment, medical management, prevention and mitigation of behavioral and psychological symptoms, and care transitions are being covered by a majority of the existing measurement sets. For other areas, there is some room for improvement. So focusing on acknowledgement and emotional support for persons with dementia, therapeutic environment, and the referral and coordination of care and services. These are areas that are covered by one or fewer measurement sets, and I think we could add assistance or persons with dementia for daily functioning activities that's covered by two. So there's some room for improvement here with improving or adding more measures to capture these vital areas. Ashley, next slide, please. So this leads us to our gaps. One gap is certainly early detection and diagnosis of dementia, and this is a highly researched and active area in the community or in the research field in the community as large. But there are other areas that also deserve our attention because there are other gaps that exist. These include person-centered care planning and elicitation of individualized health goals, formal identification and support for family caregivers, emotional support and assistance with daily activities for people living with dementia, creation of therapeutic environments to support function and quality of life, referral and coordination of care and services, and dementia-capable health systems. I see Caitlin has raised a hand. Are we taking questions along the way, or do we want to wait until later?
Zach, I think what we'll do is wait till the end and address those, yeah, orally. So thank you.
Of course. So our review again has highlighted these gaps, and this is areas I think are where we could have a call for future work to develop measures to cover these areas. Ashley, next slide, please. Now, focusing on early detection and diagnosis, something that I've become increasingly interested in from a research perspective is that a majority of people with Alzheimer's disease or Alzheimer's disease-related dementias are never diagnosed, or they're diagnosed later in the disease stage. Now, if we could shift that needle up a little bit and we could start to detect Alzheimer's disease-related dementias earlier, there are going to be numerous benefits. There are potential pharmaceutical options to slow progression. There are non-pharmacological interventions to improve patient and caregiver outcomes. We've seen those exciting results with the Pointer trial. Guidance about disease progression and support for medical decision-making for the person living with dementia and their care partner. And identification of long-term care and safety needs to best support the persons living with dementia and their care partners. And I think here I hand it off to Mary Cruz.
Next slide, please. Ashley, thank you. To ensure that we are measuring goals that account for personal preferences and what matters to the person, providers should use a person-centered care approach that actively involves people living with dementia and their care partners in care planning processes and decision-making. Person-centered care planning for dementia requires ongoing comprehensive assessments that prioritize helping people with dementia and requires asking input from the family or caregiver to fully determine the values and goals of the person living with dementia. However, persons with dementia should not be excluded from the care planning processes. Rather, identification of a person with impaired capacity should prompt additional assessment that adapts conversation to the individual's capacity to understand and provide input and identifies and incorporates a family member or other members that know about the patient's preferences. Documentation and sharing of person care plannings between all care providers is an essential component of high quality care. A dementia specific outcome that could be valuable for people with dementia and providers is a measure that evaluates whether care aligns with individuals' preferences and values. Provider can use this to assess care plan, improve communication, and supports meaningful care over the long term. One strategy for implementing person-centered care is the use of a structured care planning that explicitly addresses all the core components and identifies the intent of each component. One of the models that we refer in the paper is the NCQA approach that is used for people with complex care needs and includes those with dementia, and uses individualized goal setting and attainment tracking to determine the degree to which high quality of care is being delivered. The individual, the caregiver, and the clinician all collaborate in a goal setting process, both to ensure that goals are realistic and to facilitate reevaluation and revision of goals as the disease progresses and the needs change. This approach could be the foundation of personalized care, as cultural norms and individual-specific values and preferences are incorporated into the goal-setting process. Next slide, please. Including the role of caregiving in dementia measures requires developing and testing outcome measures that incorporate caregivers. However, currently, care delivery systems generally do not formally identify, include, and addresses the educational needs, health, and well-being of dementia caregivers. To adequately reflect the role of caregivers, measures should include all these different components: identification of family or friend care partners, formal inclusion in care planning processes, attention to their experiences of strain and well-being, assessment of need for coaching for specific roles and tasks, engagement with clinicians and community resources, tailoring resources to patient and caregiver needs, addressing access to and affordability of dementia-related healthcare. As efforts continue to improve the quality of dementia, national organizations have emphasized the need for more inclusive approaches to measure quality in care delivery. For instance, in 2016, the NASM recommended that it would be important to develop, test, and implement effective mechanisms with Medicare, Medicaid, and the VA to ensure that family caregivers are routinely identified and that their needs are assessed and supported in the delivery of healthcare and long-term care services and support. More recently, in 2024, CMS and the guide model, which is the first one in kind to reimburse direct support for caregivers of Medicare beneficiaries. And this model requires that all participant healthcare providers must make a reasonable effort to identify a caregiver for the beneficiary with dementia and assess the caregiver's knowledge, needs, well-being, and stress level, and other challenges. So the guide model represents a significant step forward in recognizing the importance of assessing and supporting the well-being of family caregivers. Next slide, please. A dementia-capable healthcare system also helps ensure that we are measuring goals that reflect personal preferences and what matters to the person living with dementia by building those priorities directly into how care is delivered and evaluated. There are many elements, all of those elements are included here in this slide, essential to create dementia-capable healthcare systems. The concept of dementia capability can apply to a clinician team, a particular healthcare setting, or community-based services, which includes several health and social systems, as well as regional government, long-term care services, and supports. There is a growing need for better characterizing metrics to assess dementia capability. One measure is the one developed by ACL and evaluates whether an organization provides a range of services and options. For instance, primary care and specialty medical services for people living with dementia, support services for caregivers, and staff training in dementia. The Dementia Capability Assessment also evaluates whether organizations have standard procedures for identifying cognitive impairment, referring people for evaluation or services, identifying primary caregivers, and determining if the person with possible dementia lives alone, as the absence of a caregiver is a source for vulnerability and social need. As Gary mentioned, the RTM framework is a model that is going to be referred throughout the presentation. And in this, it is suggested that for assessing this dementia capability, this should include all these different domains from the RTI model that measure the how the capability is necessary as a first step for promoting adoption among health systems. The Medicare wellness visit may become an entry point for assessing the dementia capability of a health system. For instance, if a person reports early cognitive symptoms or have abnormal cognitive assessment as a part of the wellness visit, measuring the rate of subsequent cognitive evaluations, diagnosis, and implementation of successive measures within this framework can be used to evaluate the degree of the system's dementia capability and identify gaps, calling for program development. And I will hand it, I believe, to Ellen.
Thanks, Mary Cruz. So I'm moving us into the recommendation phase of our presentation. There are 4 that were based on our work. The first is to increase the use of quality measures that already exist. So the table here, which I know is a bit hard to read, identifies measures from the CMS Merit-Based Incentive Payment System, or MIPS, that they're mapped across the 14 domains that we've been over. You can see that almost every domain has at least one measure identified, with a few exceptions. And I'll point out that even though detection of possible dementia does not have a measure listed, that, as was just mentioned, the Medicare annual wellness visit does include a cognitive screen, which is a step in that direction. I'll go a step further to note that there are a number of measures that are included in the MIPS value pathway supportive care for neurodegenerative conditions. Break out your magnifying glass, I think at this point, you can see in the right column that there are a number of measures that are identified with an A, and those make up the value pathway. I believe there's 8 of them, including cognitive assessment, functional status assessment, use of high-risk medications, our care plan, use of high-risk medications in older adults, quality of life of patients, education and support of caregivers, behavioral and psychiatric symptom screening and management, and safety concern screening and follow-up. So again, as was just mentioned, the CMS guide model recommends that these 8 measures in the value pathway are used by participants in guide. And I'll also say, recognize that the MIPS measures aren't perfect, but in order to really start now, increasing the use of quality measurements, then it's a place to start. And then there was a question raised by an audience member: what performance improvement measures can be instituted initially when developing a program? And I would say that for any new program, just tracking the rates of detection and diagnosis is a place to start, followed by development of comprehensive patient-centered care plans that include the caregivers, and then perhaps moving on to other measures in the value pathway. Next slide, please. So the second recommendation is to develop new measures in areas where none currently exist, such as the 3 listed here, and also for areas where the existing measures may not be adequate for some reason. And there are a couple of ongoing national efforts focused on dementia care outcome measures. The first is the Alzheimer's Association Link-AD, which is critiquing, cataloging, and promoting the use of existing measures, and also promoting the development of new measures. Then there's also the NIA Impact Collaboratory, which was mentioned previously, and Impact, through its patient caregiver relevant outcomes core, has developed a library of outcome assessments, in this case, that are appropriate for use in embedded pragmatic clinical trials among people living with dementia and caregivers. So good to know that these 2 initiatives are ongoing, and that future initiatives should align with some, or build upon some of the work that's already been done in this area. And then I think I finish up my part with another question from an audience member, which was, is there a checklist of questions that caregivers can use when accompanying a person living with dementia seeing their provider? And the answer is a definite yes. There are several good examples, and I believe, yep, those are being put in the chat right now. There's checklists from the Alzheimer's Association, the VA, and other places. And there's also a very useful caregiver self-assessment questionnaire that was developed by the AMA. And I believe the link to that questionnaire has also been added to the chat. And then I will just pass it on to Lee.
Thanks, Ellen. So next slide, please. So this is our 3rd recommendation. And I think it's really important to acknowledge that whatever changes we make, or whatever changes we recommend to quality measurement, that we're really thinking about equity. We know that there's significant disparities in dementia care access and dementia care deliveries for several different groups in the United States, racial and ethnic minorities in particular, also people living in rural areas, people living alone with dementia or without care partners, among others. And so when we think about that, it's really important to make sure that we're paying attention to race and to socioeconomic factors when we are doing quality measurement, because that will allow us to better identify these disparities, understand the disparities, and then we must act on them to improve care and to reduce disparities so that we are really seeing much more equitable delivery of high quality dementia care. And that also includes thinking about measures that are culturally and linguistically sensitive and that have been used and tested and validated in diverse populations. Next slide. Can you hear me? Next slide, please.
Is this the next
Oh,
slide?
it advanced. I'm sorry. It did
No, that's
advance.
okay.
I'm sorry. So, okay. So in our final recommendation, I'm sort of asked to kind of bring it home here with our final is to think about a consensus process for, for quality of care measurement for people living with dementia and their care partners. If you think about kind of what we've talked about today, we've got historical, several different measure sets. You saw the RTI framework. It's a very nice framework, very patient-centered, but none of the measurement sets really address everything there, right? We identified some domains where we don't really have great measures, or we're not measuring those things in care currently. So how do we move from where we are now to something that where we have a broader universal agreement about what we measure in dementia care, and that's that's pretty aspirational, but I think it's okay to be aspirational. That's how we move that's how we move things forward. And so the thought process here is to recommend a consensus process to determine a national standard for dementia care quality measures. That could be used a modified Delphi process. That's been used in age-friendly care measures, for example. There's new CMS measures around age-friendly care in the hospital. You could imagine something similar here, really focused on people living with dementia. It really needs to include a broad group of people with different expertise, not only in dementia care delivery, but also quality measurement, equity, healthcare systems and implementation, and also individuals living with the disease and their care partners, because they're really living the healthcare journey and provide incredible insight into what's important. And then we really need a national organization kind of as a convening entity here, right? If we're all doing it separately in silos, we don't really have the uptake and the impact that we had hoped to see. And I had two questions that I wanted to try to kind of focus on that came from the audience today. And one was, how should quality metrics in dementia care incorporate perioperative cognitive outcomes, such as post-op delirium? And I really liked this question because I think it can be framed in a way where this framework of quality can be applied to different areas of care. So if we were to apply this framework of quality to post-operative delirium, right, we would say we should be identifying people before their surgery who have cognitive impairment. That's that early diagnosis piece. We should be monitoring them in the hospital to make sure that if they're developing signs and symptoms of delirium, that we're interviewing early. That's that continuous care assessment piece. We should be using evidence-based multi-component interventions to try to intervene and improve outcomes. That has to do with person-centered care, reducing behavioral symptoms, the therapeutic environment, all of those components of care. We should be thinking about longer-term outcomes for delirium beyond sort of 30 days after the surgery. Like, what matters to people, 6 months out of the surgery? Did they achieve what they'd hoped to achieve? How is their cognition? How is their function? Getting at that person-centered piece of care. So I think while we don't have specific measures for post-op delirium in dementia, we can use a broader framework, right? Health systems can use this framework to really try to advance care for people living with dementia. And then my second question was, how do I know if someone that I love, my loved one, is receiving high quality care? What does that look like, and particularly with regard to care facilities or nursing homes? And I want to point out that, while we identified lots of gaps, there are, like, for example, Medicare is measuring quality in nursing homes, and you can go to like Nursing Home Compare, which is a website, and their nursing home will get a star rating. And that includes some of these quality measures that you've seen today. It also includes information about their prior health inspection, if they've had problems with that, and then also staffing ratios. And it's not perfect, but it's a place to start. And then I would say, I would, as I'm a clinician as well, I'm a geriatrician. And so I always think to my patients and my care partners, I want to empower them to ask the questions that they want to ask questions to emphasize what's important to them and their loved ones. So for example, visit the nursing home, ask to meet with the activity directors. What activities are you all doing? How does staff interact? Is the care tailored to someone's cognitive ability? Watch people at a mealtime, all of those things. It's okay to advocate for your loved one. And those are the types of high quality care that, thinking about, myself as a family member or myself as a clinician, that's what I would want to see for my patients. And I'm going to hand it over to Sue next.
Sue, we need your
I see it.
unmuted.
There
Yeah,
we go.
thank you.
Yep. Okay. I want to start, we've been diving really deep down into, I wouldn't say we're feeding at the bottom of the ocean, but we're pretty close, and we need to come up to a kind of higher level of organization, I think. So I want to reorient us for just a moment in the following way. I've been thinking about this for a long, long time, and this is what comes to my mind. What RTI has done for us, and it's really hugely important, is it's talked about what to measure, the domains to measure. And of course, there are always more domains as things evolve. Let's think for a minute about what's happened since 2016, when this framework was first published. We've had two enormous national occurrences. One is the formation of the BOLD programs, the legislation that established a mandate to develop a public health infrastructure for Alzheimer's and dementia, from risk reduction to early detection to caregiving. That's an enormous achievement for a country like ours. The second major dimension of advancement has been in biomedical science, and we're all very aware of advances in medical science and how they tend to swamp everybody's consciousness when it comes to thinking about what to do a better job with. So these advances need to be grafted on somehow to the framework that RTI established, which I personally revere because it was such an important step in development of thinking about quality. So I ask the following questions. What should we measure? What should we measure? How should we measure it? Where should it be measured? Who should do the measuring? And for me, one of the most important unanswered questions is why we should measure quality. So in many articles, the idea about what the purpose of measuring quality is to manage cost. I think that the questions that have been raised by attendees in advance that are shown here, what dementia quality dementia care means to you, this takes account of why you're all here, I think, or most of us are here. And that is because dementia, when it is managed poorly, causes unnecessary suffering. And that does translate into financial costs, but costs in health, function, and emotional state. So the why really is that dementia causes suffering. It's not because it's costly, which it is, but it's the suffering that is embodied in the experience of people who have dementia and the people who care for them. And I include everybody from friends and family to healthcare delivery systems to doctors and nurses and CNAs and community health workers and CBO staff. So what we want is care that will reduce the suffering for all of the sectors where we can even conceive of measuring quality. So here are some of the ideas that you presented. Person-centered care pays attention to overprescribing and guidance to caregivers to support the patient's quality of life. Great. Quality dementia care is person-centered. Now, I want to pause on person-centered for just a moment here because person-centered means different things a little bit to different people. Sometimes it just means that it really refers only to what a patient's goals are, what they say they want, or what they have indicated in the past that they want. But I think it is a much broader construct than that. Person-centered care is whole person care. To me, whole person care more embodies the scope of the kinds of things that we need to measure with quality measures is what are the elements of whole person care that is also person-centered, taking account of what people's own internal values historically or present in the present. So I think you all agree that person-centeredness is hugely important. I haven't seen very much in terms of things like what has mattered a lot to me, which is how we do medical care for people who have dementia. I haven't seen that come through in the questions that, or the statements that you all have made as attendees. But I want to focus for a moment on that, on the issue of medical care, because people with dementia, as we all know, you almost always have something more than dementia, and many of them have many conditions besides dementia. In other words, they are experiencing multimorbidity. And so this is the origin in large part of why we prescribe so many medications to people with dementia. It's not just because they have dementia and they may have trouble managing their own or regulating their behavior or their mood, but they also have many other conditions that themselves have quality measures attached to their management, such as hypertension, such as diabetes, such as recurring urinary tract infections. And so, person-centeredness, I would like to expand that concept beyond what a person's own values and how they feel and experience care, and beyond dignity, respect, and compassion to understanding more about what healthcare and medical care can do and cannot do. We tend to forget about that when we get into quality. Next slide. What do we,
Sue,
yeah, go ahead.
just to orient to this slide, the preceding one and the one that's up now, I know you mentioned it. I just want to clarify that all of these bullet points came in from registrants for the webinar today. And what we did was organize them into these four categories to show the general sentiments and thoughts that people registering and here at the webinar today have on their mind regarding what quality dementia care means to you. So.
Yeah, thank you for that kind of big picture description of where these did come from. And so I think if you read through them, I'm certainly not going to read through them. It's a pretty comprehensive approach to what might be thought of as how to live well with dementia. How should quality measures promote living well with dementia wherever the person is, whatever their problems, where they live and get their care, and what they wanted out of life. And so um, this is the framework that is the most difficult really to measure. We can measure some of it. Gary, you had mentioned the hospital measure of patient experience that's used in every clinic these days, every hospital stay. What was your experience? Were people respectful? Did people understand what you wanted? That's a really good start for this. I think we could probably improve on it quite a bit with current measurement strategies on making it more meaningful than it actually is today. But I think it's a really fine place to start. What is the experience of care for a person with dementia to the extent that they can express it, and for the people who care for them every day when they're in their home setting, whatever that setting is. In terms of maybe a minor comment, but something that I think matters a lot when we think about how you measure quality of care for people who have dementia at more advanced stages. One of the ways that I think we haven't paid enough attention to is here bulleted here under whole person quality of life, understanding how and when to respond to anxiety and aggression, but also how to understand and when to respond to symptoms that look like depression. And so I think we need to be centering in our quality measures that address patient experience in more advanced stages. How do they look? What does their affect show us about how they feel inside? And is their behavior a reaction to it is an expression of distress always. And so what are the distressing factors that are leading to that behavior? So all these things are known, but they don't appear that much in quality measures as we have them today. So if we were thinking about expanding the hospital-based measures of quality, patient experience quality, and we need to add caregivers, and we need to add dementia-specific elements for people who can't really tell you very much about what they're experiencing. Next slide, please. So here, reviewing the framework, the 14 elements of the framework that has organized this entire effort. I think it was Ellen who divided this up, right, Ellen? You categorized where across the 14 elements who these quality measures were meant for. So
Joint effort. I categorized and then Gary created this wonderful crosswalk.
yeah, well, would you like to talk about that a little bit more?
I can, sure. Um, so the the reason for the color coding was to just look at the four general categories of what quality dementia care means to you from the registrants and show that they really are cross-cutting over most of the framework elements from RTI. And as you were saying, Sue, a lot of these reported quality components that the registrants here today suggested related to person-centered care, dignity, whole person care, caregiver inclusion, they relate to the experience of care more than to separate elements the way that RTI divided up the elements of care. And so the big picture message here is that experience of care, of being valued as a person, as an individual, having the care plan individualized and specific for that person living with dementia, that those experiences of care are what people are thirsty for in quality measurement. And that may be another gap that we didn't highlight in the manuscript. We didn't highlight the importance of the need for experience of care measures as well as we might have in our discussion. And it was very nice to see it highlighted by those who answered that question when they were registering.
If I might draw a contrast here, this is a conundrum, I think, for the quality field, because quality measurement really originated with the idea of accountability for cost, right? If I'm going to pay for something, I want to be sure that I'm getting quality back for what I buy. And in this case, it's CMS, it's the Medicare administration, Medicare and Medicaid, it's insurers, it's to some degree, to actually a large degree, families when it comes to long-term care cost. So it has to do with accountability. I mean, this is the way we've thought about measurement here is accountability for elements of care that we're going to buy. And most of what you and the audience have asked for is exactly what Gary said, which is something that is much more personal, much more intimate, much more emotional, much more about um, living well in spite of disabling cognitive impairments and usually physical impairments too. So thinking about it that way begs the question of who should be what is it that we should be trying to put into a different set of quality measures. We're not talking today about actual delivery of medical care. That's a different topic that wasn't touched on deeply here, medical care per se. But it does touch on your requests for person-centeredness and positive experiences of care do touch very closely onto the delivery of medical care. How do doctors interact with people who have dementia? How do staff in nursing homes interact? And this speaks to the whole set of skills training in how to understand the communication of people who have dementia. This takes us far beyond the mission of today's webinar, but it's something that I think we will need to bookmark and come back to in the future about how do we measure training in person-centeredness, in community, in understanding a person's condition when they have dementia and working with them. We know that there are people who are gifted this way, who get it and don't need training. They're naturally gifted. Some of them are community health workers, some of them are CNAs, some of them are checkers at the supermarket, and some of them are doctors and nurses. But to spread that kind of quality development is a whole other endeavor that I look forward to our joint contributions to in the future.
Thanks, Sue. I think are we ready to close out section 1 and move Joe back to your facilitated part 2?
Yes, definitely. And I think I've been obviously monitoring the Q&A box. And again, everyone, for those attendees in the audience, please do feel free to pose questions in the Q&A box, and we're going to get to them. I know our panelists have already been answering quite a few of them, actually most of them already, which is great, and we'll have some additional ones here as well. I'm going to take my prerogative as the host and start this off, and it's really going to dovetail on what you immediately talked about, Sue. And I'd love to hear the panelists is, we do have another, at least another 38 minutes or so. Why don't we take a shot? And I'd like to start identifying what are the competencies. I mean, I think that's what you're getting at, Sue, right? In terms of competencies of training, quality in dementia care, training of professionals of quality dementia care. Can we come to some agreement on general competencies that are needed? And maybe there's prior work we could call upon to do that. Again, I'm not as familiar with that. Maybe some of you are, but I'd love to hear your thoughts.
Can I make a comment about this? Because I'm stymied by the question. Because when you really look at the array of settings and people and kinds of things that need to happen for really good care of people with dementia and everyone in their network, I just sort of explode with complexity. And for me, I like to think in terms of maybe the wrong terminology, but something like a local quality council, that anybody who is involved in this endeavor of providing care for people with dementia works in a setting of some kind, and that they start with the setting. And what are the kinds of things that are appropriate for their setting and for their role? And build upward from that. We can certainly build from the top and go down, but you get so fast into the complexity of it. I'd love to hear what people might have to say about what are the core competencies for, something dear to our hearts, Joe, the community health workers. What are core competencies for community health workers who are working in the dementia space across the spectrum? What are the core competencies? So you can divide it by discipline, by professional activity and job role. And then you can divide it by setting. Then you can divide it by type of intervention. Is it medical intervention? Is it surgical intervention? Is it pharmaceutical intervention? Is it personal care assistance? etc. But I'll leave it there and turn it back to everyone.
I'll take
Mhm.
a point to respond, Joe, and just
Yep.
acknowledge a little surprised to grow from dementia service delivery quality measures to workforce evaluation, but it's a great question. It makes complete sense to ask it. Um, the short answer I would have is that there's research underway to assess what the dementia care workforce is.
Yes.
So there's a large dementia
Yep.
workforce project, and I'll be really curious to see the outcomes of that. So we just know who are all the workers in that are having contact with people living with dementia and their caregivers to be able to define the categories of care that's provided, both from community-based organizations and in clinics. And we need those categories in order to then assess the quality of the care delivery by them. So it's kind of punting around your question, but acknowledging the importance of it.
I'll add something too. I think that one of the reasons to measure quality of care, right, is to find out where you're not doing a good job, right? You can't improve what you don't understand. And I think to that same point, when you understand what you're not doing well, then across health professions trainings programs, we need to think about how we alter training to improve that. So there are competencies, around health professions and dementia care, but you don't see a lot of it in training. So as a physician, in medical schools, I don't think we have enough of that. It's probably true across the board, right? We don't have enough, the dementia care specialty training coming out of our health profession schools, or, there are people making strides in this, right? In pockets, there are individuals working very hard. Like we have a dementia training program in community health workers, right, in Oklahoma, but we haven't seen broad uptake. We don't have a national consensus on what we should all be doing. And what I think we hope to do with this paper is bring light on that. If we could try to measure some of the same things, we could identify where we have problems, and then we could really make system level changes within health systems, within training programs to try to improve care for people living with this disease.
So this
If I could
this
add
leads
one,
us.
oh,
Oh,
sorry, go ahead, Sue.
no,
Well, I was
you
just
ask.
gonna say, if I could add one point, I think from like a wearing a caregiver hat, that the people that are the most impactful in the lives of people living with dementia are the ones that are with them hours and hours, day to day to day. The CNAs, I think, or I guess like the community health workers, important for the physicians, the nursing staff and all, but those other types of workers really have a huge impact on day to day quality of life, I would say.
So I'd like to pose a kind of research question that comes from what all of you have just been saying, and that is, I would really like a broader view of what quality is from each of the disciplines. So what we've got so far is a consensus on the absolute requirement for something that people think of as person-centered. People with dementia are people. Each one is a person. Each one has experiences, regardless of whatever their limitations might be or how severe they may be. Nevertheless, someone with pretty advanced dementia, maybe not terminal dementia, but pretty advanced dementia, can know when somebody is being kind to them. And you can see that in their body language and in their emotional expressions, their affect, right? And so we've undertaken a bit of a study of what primary care clinicians think uh, what are the values of primary care clinicians when it comes to delivering care to people with dementia. And this work is very, very preliminary. It turns out that primary care clinicians who do most of the care for people who are still living in the community don't have a very clear idea of what high quality care would be. What most of our interviewees said about it was that they considered high quality care to reflect what the patient and the family valued. So that should reassure our attendees today that primary care clinicians are thinking about that, thinking about uh, providing care that aligns with the goals and wishes of patients and families dealing with dementia. But that's only a start. That doesn't tell you how to train a primary care clinician to do good dementia care, which I think Lee is talking about. Um, and who does get trained? Nurses don't get trained except on the job. There is no requirement of dementia care training for RNs. And there isn't really dementia care training for nurse practitioners either, except through geriatrics. Yeah, I mean, there's specialty training, but it isn't required. So there can be some required gerontology, geriatric training for nurse practitioners, but not dementia training specifically. So, and there is no requirement for physicians seeking relicensure in their state to have any background or training in dementia except in a very, very small number of states. So that's a whole other spin on quality is the regulatory environment for licensure of health professionals who are dealing with it. And to your point, Gary, the workforce study that's currently being conducted, the dementia workforce study is really a great start, but it doesn't include community health workers, for example.
Yeah. You know, looking at some of the questions here again, and I think it's very related to what we're talking about, is I see Renee Kidney here from the Minnesota Department of Health has joined us, and she has provided some comments here about ACT on Alzheimer's. And she had mentioned that some of the work, some of the things we're talking about, at least in part, was one of the original objectives of ACT on Alzheimer's, which began in Minnesota. Some of you may know this more from terminology like dementia-friendly communities or dementia-friendly America. ACT on Alzheimer's, I think, kind of transitioned into that work nationally as Dementia Friendly America. But essentially, these community-led efforts to train people in various settings to help people be better supportive people living with dementia and their care partners. As Renee had mentioned, these included initiatives of reaching out to not just clinical settings, but grocery stores, libraries, law enforcement, I mean, et cetera. And certainly in the state of Minnesota, several of these dementia-friendly communities still exist and are active. I can think of Winona, Mankato. There's several others too. Others started and maybe weren't sustained. But, you know, in thinking of some of your comments, Sue, and others here on the panel about these maybe more contextually focused efforts, I mean, how does that align with this whole idea of measuring dementia quality? And maybe in a larger sense, and maybe I'm kind of focusing on what I'm interested in, I apologize, but trying to get to the point where can we ever measure dementia-friendly community efforts? I mean, what do people think of all that? Sorry, it's a lot of things I covered there, but please.
Yeah. Joe, in I think it was the background section of our manuscript, we did reference work that Administration for Community Living did on dementia capability.
Yeah.
And that gets at some of what you're describing. In the RTI framework, there is the one element of environment of care, which, as you also just explained, there's so many sub-elements, and I'm a strong supporter of the Dementia Friendly America movement. And looking at their materials, there's lots of subcomponents of the environment in which people live that all could have their own individualized assessment. So I think the best we have for a framework for measurement of the environment is the dementia capability work that ACL has done, but it is another area that could definitely benefit from more attention.
Good. We have another interesting question here from Joe Costello. And love to hear the various panelists' thoughts on this. How do the completeness and accuracy of cognition-related EMR, electronic medical record entries, affect the quality of dementia care, and what's being done about this?
So I can speak to this a little bit. So I think one of the things that happens often is if cognition is evaluated, which is what we want, right? It's often put in free text in a note. And so then, how you then pull that out and find that, or how a person would find that, and how that would then inform how you might think about all of the components of care for the individual, right? Not just their dementia care, but their heart failure care and, their diabetes care and all of that, right? And so that capturing it in a way that it gets in front of clinicians, I think is really important. I think there are examples of that where health systems are doing that. And I think there's also tremendous potential with AI, as we see AI more and more within electronic health records to help clinicians sort through a lot of the data and bring things that are really important. So I think that is potentially another area of work within implementation to try to improve dementia care is, if we are measuring it, how are we then capturing it so that it's useful to clinicians, so that it is actionable. I think that's always been kind of a challenge, but I think we have more powerful tools than we've ever had. We don't know how to use them well yet, but that will come, I hope, or at least I'm optimistic.
Can I jump in on the tail of that comment, Lee, about the quality measures that we've been talking about today are largely related to the processes of care, the kinds of things we ought to be able to offer and provide to people in a broad humanistic way. But what we have a lot of trouble doing in the dementia field is figuring out clinical outcomes that we can actually move, by anything anybody does. So one of the things that has been movable to some degree, but to a very limited degree so far, is hospitalization rates. If you really set your mind, if you are a health system concerned with the use of acute care services by people with dementia that might be avoidable. This has been part of Healthy People 2030, reduce avoidable hospitalizations for people with dementia. Well, truthfully, it's really hard to do that at a system level. It's hard to reduce hospitalizations. It's hard to even identify which hospitalization might have been avoidable and how might it have been avoided. If it was avoidable, how far back do we have to go in the life of the person who's now hospitalized for an acute problem, like an acute UTI, okay, with delirium? How far back in their life pattern? Is it a week? Is it 2 weeks? Is it 3 weeks that we have to go to prevent that admission? I think we should prevent that admission, but I think we only do it when we know what people are at risk for. And what people are at risk for is not only generic because they have dementia, they may have frailty and multimorbidity as well, but because they are individuals who have particular vulnerabilities. And so that's you mentioned AI, Lee. I think this is one of the great applications of AI, is to eventually be able to really create a risk profile for people living with dementia, um, in order to try to locate empirically where they are and what are they likely to be experiencing in the future, that if we target now, we could prevent it. That would make a huge difference in the lives of patients and their caregivers, I would say, if we could do more of that. We have examples of how to do it with certain very limited medical complications of dementia, like UTI. We know how to do it with UTI. We don't do it with UTI, but we should because we know how.
Great. You're getting praise in the comments here, Sue. Thank you. There's another question here. I think we all agree it's an essential one. It's by Mary Martha Stewart, and love to hear the panelists' thoughts. Is how about asking people living with dementia for their perspective on high quality care and quality measures? Is there any report on this? And I think many of you have important perspectives to share on this.
There have been some publications on this. I wish I could cite chapter and verse. I cannot off the top of my head, but there are publications. That get us maybe one step in the direction that we'd like to go. People want to be at home. I mean, I think that tends to be a common theme, right? High quality care allows me to stay at home. How about the
What do others on the panel think while Sue helps to save her voice here? Yeah.
Um, Impact has done a little bit, Impact Collaboratory and the patient and caregiver reported outcomes core. Is that correct, Ellen, that there's been some work to prioritize measures related to sort of the definitions of person-centeredness and what people living with dementia and caregivers prioritize as the important elements to measure?
I would say in combination with other parts of impact, like involving the lived experience panel, that was a joint effort between Impact and the Alzheimer's Association. And one of the first set of meetings that that group had was about what outcomes really matter to you. So I think there's a report out there on that. That's, it doesn't get into a more sort of in the weeds specific level, but it gives a sense of what types of outcomes are important to patients with dementia and caregivers. Yeah.
Yeah.
So yeah, everyone, I think we've been throwing around a lot of acronyms today. For example, RTI, not everyone knows what RTI is, so we clarified that. So what is Impact Collaboratory? So I'm not going to spell out the acronym for you, but what National Institute on Aging Impact Collaboratory is a very large effort supported by the National Institute on Aging to find better ways to embed dementia care innovations into healthcare settings. And this is done by what is called pragmatic trial methodology. And again, there's no need to go into depth in that. But essentially, it's trying to conduct research for people living with dementia, their care partners in healthcare settings that mirror real world conditions. The thought being that by doing this, we can better get innovations out there to benefit the most people possible. And so the work that Ellen and Gary have led and continue to lead that is very essential to this work is getting exactly at what you're talking about, Mary and Martha Stewart, and asking about, which is we cannot effectively disseminate and implement these innovations if we don't ensure that these innovations are addressing and improving outcomes that matter the most to people living with dementia and their care partners. So how do we capture that? How do we assess that? How do we measure that? And so what Ellen and Gary and others have done is to pull together teams, pull together lived experience advisory groups and other initiatives to really start to move us in that direction. Because for too long, many of the measures we use to understand the effectiveness of an intervention, a dementia care innovation or whatnot, often have little relevance to people's lives. There are measures and outcomes that people, quite frankly, don't care a whole lot about. They want measures instead that get at things like Dr. Borson was talking about. Will this help me stay at home longer? Will this help me live a better quality of life? Et cetera, et cetera. Okay. So, all right. And thank you. Looks like in the chat, Dr. Jennings also put Link AD, which is another, yet and again, another acronym, but another initiative that has also been trying to grapple, that has been trying to grapple with, again, how do we create better measures that center and elevate the experience of living with dementia and care partners, and using those as metrics of quality, success, et cetera. Again, it's a lot of work. And, another set of comments I think that have been coming out, I've been noticing in the UK is this whole idea of incentivization. How do we incentivize healthcare providers and others to provide this multidisciplinary care, this care that we believe and think is necessary to optimize, quality dementia? And I'm going to stop and leave it to the panelists to maybe reflect on some of these thoughts.
So I think we've had pay for performance for quality measures for a long time, but I think one of the most powerful ways that we can actually change care delivery is through some of the focus on on dementia-friendly communities. If we have a culture change about what dementia care and our communities look like for people living with cognitive impairment and their care partners, then and if as providers we live that, we embrace that culture, we have our patients embrace it, we expect it, that culture change piece is really powerful. And so I really hats off to the people participating today who brought up the dementia friendly communities piece, because I think that's really important.
Could I mention that our Center on Early Detection has been in conversation, and I know the other centers of excellence under the BOLD Act have also done this, but we're particularly interested in Dementia Friendly America as a linchpin of the public health system that is really kind of an unsung part of public health.
Ooh, I'm sorry, I didn't mean to interrupt. Do you want to just describe to everyone what BOLD is and why it's important in this context?
Yes, BOLD, building our largest dementia infrastructure, is a federally mandated, it's a legislated set of principles about creating public health infrastructure across the country that addresses dementia, both from the standpoint of risk reduction, early detection and diagnosis, and care. These are the elements that are required for a robust public health system for dementia, and it's been in operation. The legislation was passed in 2018. The three centers of excellence on risk reduction under the Alzheimer's Association, early detection that I'm involved with at NYU Langone with Josh and caregiving, which Joe runs in Minnesota. These three centers were tasked with helping to craft a overarching framework for dementia public health as enacted through the states. So there are now 43 states that have BOLD programs funded by the same legislation to try to accomplish progress in a public health view of what people with dementia and their families need and how to deliver it. So we're now in our 6th year of operation, and this may be our last, depending on what happens with the federal government. But it was a revolutionary development of the same order, I would say, as discovery of amyloid targeting therapies. Now, whatever you think about amyloid targeting therapies for Alzheimer's disease and whether they do a great good thing or not so much, that isn't the point. The point is that there's now science that allows us to do something we could never do before. And we also now have legislation that allows us to do something in the public health sphere that we could never do before because there was no infrastructure. So thinking about where does the dementia-friendly communities and dementia-friendly America fit into this? They are really the on-the-ground public health, the unsung public health partner for all of this work. So we in our center have been talking about how to help dementia-friendly communities and the Dementia Friendly America organization become evidence-based, articulate what it does, and build on what it does to create, to really give it legs as a public health initiative. I can stop with that, but well, I don't want to stop entirely because it speaks to the sense of value that people with dementia have. This was the first attempt to codify community efforts that made people with dementia feel as though they belonged. And they did it through things like dementia cafes. What a wonderful thing. Dementia cafes are a wonderful thing. They are social events with food, all the better for people who otherwise may have no social contacts because they.
Yeah, and I think there's a national movement around this, Sue,
Yes.
Dr. Boris, and everyone. And I think what they call our memory cafes. I think that's kind of what the term they've been using to capture what Dr. Boris is talking about.
Because it avoids the stigma of the term dementia.
Yeah.
Yeah. So just, I think I'll stop there, but I think what we're seeing is that we've got enormous potential across many different strata and organizations and funding streams do big things here to really provide high quality dementia care across the board, from home care to healthcare to community care to person-centeredness and respect. And that's what I think, Lee, yours and Gary's initiative to get this paper going has allowed us to bring together all of the different quality thinking that has going on and is latent and begun to give it a voice. And I thank you so much for doing that.
Thank you, Sue. And your description of the BOLD initiative, it reminds me of our manuscript's recommendation 4 about a consensus on dementia quality measures. And that process of consensus needing a home. And I could put it out to you and to Joe as to whether BOLD might be a place to move this forward. Um, we would need a location, the Alzheimer's Association or otherwise. Um, ASPE, HHS, which is the evaluations component of Health and Human Services, federal government could be another. They are the ones who contracted with RTI to produce the measures framework initially. But it's a strong recommendation from our manuscript that we do move this process forward. We identify a central way to reach consensus, and it's complicated to do. And since we published this, Ellen, you pointed out to me that Australia has come forward with a multi-year process in which they defined dementia quality in Australia. I don't know if you could comment a bit on how complex it is when a nation goes forward with doing something like that. You're muted, Ellen.
The reason we find these examples in places like Australia and the UK is because, federally funding of core outcome set development is not something we do here in the US. But it's really a process, and there's the Common Initiative in the UK that has guidelines for how to do this core outcome set development process. And it really starts with, it's a very top-down level as opposed to what we've done here, which is like looking at what's out there and identifying what's missing. It starts at the top of what are the domains, what are the outcomes, and then getting everyone, the clinicians, policymakers, patients and caregivers, everyone at the table to do this sort of multi-step consensus process. So it's elaborate, expensive, and not currently funded readily in the US. So I think your point about finding a home for work like that is really a good one.
I did want to note, oh, I'm sorry, did I interrupt somebody?
Oh, I was just going to say Canada is undertaking something pretty similar. And I'll mention for the audience that an organizing principle of their quality development there is patient experience or personal experience.
Yeah.
Very experience-based.
Very much, yeah.
Go ahead.
Couple things I wanted to note here as we kind of start to wrap up our time. Thank you, Morgan Davin, who shared what looks to be a very interesting paper on some of the work related to components and standards dementia care navigation. Morgan, I've actually shared that publication with our BOLD colleagues related to some of the work we're doing in advancing community health workers' role in dementia vis-a-vis our BOLD and public health work. So thank you. And also to looks like Bethany here from Dementia Minds, sharing a very interesting report here on transforming life with dementia. Thank you for that. And again, that's in the chat for everybody too. I would like to just turn it over. Any final thoughts, comments from our panelists here as we wrap things up?
I want to thank everybody for showing today and for being so engaged. This is life work for many of us, right? Getting to something that looks like high quality care. And so thank you all for being here and for your questions and comments. And I want to invite you to get in touch with us through our centers if you're so moved.
Yes, please do. I noticed that there were some conversations happening between some of the panelists and audience members. Hopefully those can continue. Otherwise, thank you everybody so very much for attending today. I really want to have a big thanks to the panelists for the great work they're doing in what's really a space that is very complicated. And, there's been a lot of effort put towards this by Dr. Epstein-Lubau, Dr. Borson, Dr. Jennings, Dr. Tambor, Dr. Kunicki, and then also Dr. Rivera Hernandez. So again, thank you all for being here and your wonderful work and having an opportunity for us to share this with the broader community and what it means to how we better understand how to optimize care for people living with dementia. Again, a reminder, and you'll get this as well when leaving the webinar today, we please ask you to complete the webinar evaluation. It helps us and our Minnesota Geriatric Workforce Enhancement Program. You see both the QR code here as well as the link. You'll get this as well as links to the recording of today's webinar and the slides too. Thanks again, everyone. Really appreciate the wonderful conversation and knowledge exchange. And again, as Dr. Borson had mentioned, if there's anything we can do, please don't hesitate to follow up with us. Otherwise, thank you, everyone. Take care.
Thank you.